Management of impacted third molar. Definition. Impacted tooth. A tooth which is completely or partially unerupted is positioned against another tooth, bone or soft tissue, so that its further eruption is unlikely and described according to its anatomic position. Etiology of impaction, local causes. Irregularity in the position and pressure of the adjacent tooth. Density of the overlying or surrounding bone. Localized chronic inflammation. Lack of space due to underdeveloped jaws. Obstructions. Dilacerations. Over-retained deciduous teeth. Ectopic position of tooth bud. Systemic causes, general causes. Prenatal causes, heredity. Postnatal causes. Rickets, anemia, congenital syphilis, tuberculosis, endocrine dysfunction, malnutrition, rare condition. Cleidocranial dysostosis, progeria, osteopetrosis, and cleft palate. Indications for removal: infections, unrestorable tooth, periodontal disease, dentigerous cyst, external resorption of the second molar, buccoverted impacted molars, prophylactic reasons, fracture, atypical pain from an unerupted third molar, contraindications. Impacted teeth, which are likely to erupt successfully. Partially impacted teeth, which can be used as an abutment. Medical history contraindicates surgical procedure. Deeply impacted third molars in patients with no history of any bony pathology to avoid damage to the vital structures. Third molar should not be removed in patients where the risk of surgical complications is judged. Classification. Based on the nature of overlying tissue, Winter's classification, Pell and Gregory classification. Based on nature of overlying tissue, we have got soft tissue impaction and hard tissue impaction. Soft tissue impaction. The presence of dense fibrous tissues overlaying the teeth sometimes prevents its normal eruption. This is frequently seen in cases of permanent central incisions, in which early loss of primary teeth with subsequent masticatory trauma to the ridge results in fibrosis. Hard tissue impaction. When the teeth fail to erupt due to obstruction caused by the overlying bone, it is known as hard tissue impaction. Here, the impacted tooth is completely encased in bone so that when the soft tissue flap is reflected, the tooth is not visible. Extensive amount of bone must be removed and the tooth may require sectioning before removal. Winter's classification, we have got mesioangular impaction, distoangular, horizontal, vertical, buccal, lingual, and transverse impactions. Mesioangular impaction, diagrams showing mesioangular impactions, distoangular impactions, horizontal impactions, and vertical impactions. Pell and Gregory classification based on their relationship with the anterior border of the mandible. Class 1, the anteroposterior diameter of the tooth is equal to the space between the anterior border of the ramus of the mandible and the second molar. Class 2, a small amount of bone covers the distal surface of the tooth and the space is inadequate. Class 3, tooth is located completely within the ramus. Based upon the amount of bone covering the impacted tooth in relation to occlusal plane, position A, occlusal plane of the impacted tooth is nearly in the same level as the occlusal level of the adjacent second molar tooth. Position B, occlusal plane of the impacted tooth is in the midway between the cervical line and the occlusal plane. Position C, occlusal plane of the impacted tooth below the level of the cervical line of the second molar tooth. This can be applied for the maxillary teeth as well. Based on log axis of the impacted teeth, it is similar to that proposed by Winter. It can be mesioangular impaction, distoangular impaction, vertical, transverse, buccal, or lingual version. Radiographs. Intraoral periapical radiograph, bite wing, occlusal, lateral oblique, OPG, and CBCT. War lines. There's a white line that is drawn on the occlusal surface of the erupted mandibular molars and extended over the third molar region posteriorly. The axial inclination of the impacted tooth can be seen apparently. The occlusal surface of the vertically impacted third molar is parallel to the white line. The occlusal surface of the third molar with the distal angular impactions meet the white line in front of the third molar. The occlusal surface of the third molar with the mesial angular impaction meets the white line behind the third molar. The occlusal surface of horizontally impacted third molar meets the white line in perpendicular direction. And this is a diagram indications. The depth of the tooth within the mandible, relationship of occlusal surface of the impacted tooth with the erupted molars. B for the amber line. Amber line is drawn from the surface of the bone on the distal aspect of the third molar to the crest of the interdentine septum between the first and the second mandibular molars. This line represents the margin of the alveolar bone covering the third molar. And the red line is an imaginary line drawn perpendicular from the amber line to the imaginary point of the application of elevator. Usually this point is a CEJ on the mesial surface of the impacted tooth. The length of the red line indicates depth of the impacted tooth. With each increase in length of red line by 1 millimeter, the impacted tooth becomes 3 times more difficult to remove. So this is a box representation of war lines. Assessment of roots of impacted third molar. Position and root pattern of the impacted as well as the adjacent tooth might be considered. The eruption status of the impacted tooth should be assessed before the status of formation of root determines the time of removal. Length of the root. The ideal time for removal of the impacted teeth is when the root is 2/3 formed. In this stage, the root will be blunt and removal is very easy. When the root is 1/3 formed, as the tooth tends to roll into the crypt like ball in a socket, which prevents the easy elevation. If the tooth is not removed during the formative stage and the entire length of the root develops, the possibility increases for abnormal root morphology and for the fracture of root tips during extraction. Fusion of root. The root may be fused in a single conical root or a separate distinct root. The fused conical roots are easy to remove than widely separated roots. Curvature of the root. The curvature of the tooth roots also play a role in the difficulty of extraction. Severely curved and dilacerated roots are more difficult to remove than straight or slightly curved roots. The apex area of the radiograph should be carefully assessed for the presence of small, abnormal, and sharp roots that would fracture during removal. Convergent roots are comparatively easier to remove than the divergent roots. Width of the root is also important. The total width of the root in the mesiodistal direction should be compared. The roots of the second molar should be compared. If the second molar roots are smaller in relation to the impacted tooth or the fused end, the conical care must be taken not to luxate the second molar during the elevation. Similarly, absence of first molar leaves the second molar unsupported. During the elevation, inadvertent luxation or dislodgement of second molar should be avoided. There is Pedersen scale for modification of Pellen-Gregory scale. Surgical removal of impacted third molar. Procedure for surgical removal of tooth involves depending upon the following factors: the degree and type of impaction, amount of soft tissue exposure, amount of technique of bone removal, odontectomy. Anesthesia should be given. Incisions should be warts or modified warts incision. This is the diagram for warts incision and the modified warts. Elevation of the flaps is very important to allow the adequate exposure of bone and the tooth. Bone removal, the amber line determines the amount of bone covering the impacted tooth which has to be removed for applying the elevator to remove the tooth. The red line determines the depth of the point of application of the elevator. When the entire crown lies above and in front of the amber line, there is no necessity to remove the bone. In other cases, bone must be removed. Removal of bone with burr. Moore-Gilby collar technique. The burr is used to create a gutter around the neck of the impacted tooth. On the buccal and the distal aspect, the bone must be removed to expose the entire crown till the CEJ. Removal of bone with chisel. Buccal bone may also be carved away by chiseling. When using chisel for removing the bone in the mandibular third molar region, the mandible should be adequately supported. Removal of tooth. The removal of bone should establish sufficient space between the ramus of the mandible and the second molar for the removal of tooth. The straight elevator should be applied on the mesial CEJ. Care must be taken not to injure the lingual nerve. Debridement and closure of the area is very important. The wound should be debrided. Periapical curettage should be done. The wound should be now closed with sutures. The initial suture is placed on the distal aspect of the third molar. Sometimes the wound may be left to heal by granulation tissue formation. There are other techniques like the lateral trephination technique. The procedure was first described by Bowerdel Henry. Technique, local anesthesia is preferred over general anesthesia. Once anesthesia is secured, the external ridge is palpated, S-shaped incision given. Lingual split technique or the calcify technique is also very important. The method was first introduced by William Calcify. It takes advantage over the thickness of the lingual bone. Thank you.